Thanks, Mary. Thanks, Nick. It's really great to hear what our teams are doing to support our customers. On to our final session of the day. It is one of our most favorite, most popular sessions. But before we go there, I did want to mention that AVA Prize from 2019. That was Kim who held that up. Normally we do that at this time in our symposiums. We had so much content going on that we're actually going to do that before the end of the year. There'll be a special session and an awards ceremony, virtually, if you will, for that. So stay tuned for more information on AVA prizes this year in 2022. So on to our last session, tips and tricks from Monitor Staff Pros. Has some of the most successful monitoring staff from across the U.S. sharing best practices that enhance patient and staff safety and the patient family experience of care. So I'm happy to introduce our next speaker, Stacy Overholt. She's our Clinical Director of Program Success. Take it away, Stacy.
Thank you. Oh, hi, everyone. All right, what an honor to be here today, and I am. This is typically a session done by our beloved Pat Quigley. Unfortunately, she couldn't make it today, so I am the fill-in. So I hope, Pat, I do you justice. Very excited for this panel. We get to talk with some monitor staff from different parts of the country, and it's really, really important for you all to hear the voice of the monitor staff and the program managers who manage the monitor staff to hear what they need to become part of the care team. And so today I'm going to introduce you to Kirsten and Juliet. I'm going to ask them to introduce themselves, let you know where they're from, and if you both could answer, how long you've been working in the position and what hospital are you at, and what your actual role is. We'll start with Kirsten.
I'm Kirsten Winder, and I am from Wichita, Kansas at St. Francis Hospital of Ascension. I have been in my current position for a little over a year, but I am a supervisor now for this department. Prior to this, I was in the monitoring team as a monitor tech for 6 years.
Great. Juliet.
Okay, I'm Juliet Anie. I'm the lead LVN for the Dallas VA monitor station here. I've worked as a bedside LVN for 10 years in a long-term care area. I've been the lead for this Telemetry program here for 2 years.
Great, thank you both. We're so happy to have you here. And on a side note, I'm going to call you out, Juliet. Juliet is an award-winning monitor tech and monitor Telemetry program manager. She, in May of 2022, this year, won an award for the VA. It's the National VA Secretary's Award for Excellence in Nursing and Advancement in Nursing Programs for Non-Staff Nurses. And the recognition for Juliet was for optimizing the North Texas VA's Telemetry program. And you got to go all the way to Washington, D.C. to get that award,
Yes.
didn't you?
Yes.
I bet that was exciting.
Yes, it was.
Yeah. Okay, so this question I love because I've been with AvaSure for quite some time. And when we first started back in the 2010, it was, what's telesitting and what is a monitor tech? Is that a telemetry tech? And the answer is, of course, no. There's other things that these staff members can monitor. So what do you say to people who either aren't in the healthcare field or who are and have never heard of telesitting, what it is you do when they ask you that? Let's go with Juliet first.
Okay. Pretty much patient safety and staff safety. So it's not all about just the patient alone, including staff who let them know they might go into the room and a patient is probably acting out, fighting the staff, they're trying to provide care. We can get another staff member to come into the room and assist them. So it's not all about the patient, it also includes our staff also.
Great. Kirsten, what do you say to people?
I also say something similar to that. I just say that it's for patient safety as well as staff safety, and that we just ensure that the patients are well taken care of.
That's great. That's great. That's such an important part of the care team too. All right, let's go back to when you first started. You're both seasoned. Juliet, you're more managing monitor staff. Kirsten, you're more the lead monitor staff and a manager, but maybe doing some monitoring as well. But take us back to the very first time you sat in that chair and you had the screen in front of you and you had multiple patients in front of you, and you remember verbally redirecting the patients for the first time. Tell me a little bit about that and how you felt when that patient hopefully listened to you and sat back down in the bed or whatever it might be, Kirsten.
I was just very excited. I was just very excited to be able to help the floor staff and not have to, I was able to manage that patient and ensure their oxygen stayed on. And I remember just being so very excited to be part of it because we had never seen it here before.
And in addition to that, when you felt that and you had that experience for yourself, when was the first time you actually got recognized by a floor staff member that said, wow, that really helped? Tell us a little bit about that.
I would say probably within the first week that I had started working in the monitoring department, we were recognized for helping and relieving the staff of some of that load of having to go in constantly and, keep a patient in the bed or keep their oxygen on. I remember one of the staff members called me. We had worked bedside together prior to my becoming a monitor tech. And she said, "Thank you so much. I'm just so glad that you're watching my patient." And I was just really grateful to be acknowledged.
Did you say, Kirsten, that was within the first week of your program?
Yes, ma'am.
That's fantastic, fantastic. Juliet, I want to hear your experience and when you first were able to interact with the patient and they listened, and then when you first got recognition from the staff.
So pretty much, most times I'll say my monitor techs are the ones doing the monitoring most of the time. So maybe I have to cover them for a break or something. To me, it's kind of different because being a bedside nurse for a very long time, I'm used to going to the room, speaking to the patients, redirecting them there and then. But this is kind of different where you're speaking to them and they cannot see you, but you can see them. So there was a patient, I think he just was trying to get his urinal, but his urinal was kind of far from the table. So I noticed he kept trying to get up. He would lay back down, and I asked him, I said, "Sir, can I help you?" And he said, "My urinal, I need to use the urinal and it's far." So I called the nurse and I said, "This patient is trying to use his urinal. Can someone go into the room and make it reachable for the patient?" And luckily, when the nurse went into the room, there was a spill on the floor where the patient was. So she went in right away to get a towel to kind of wipe it. And after giving the patient the urinal, she called me back and she said, "Oh, thank you." She said, if that urinal was close to that patient and he stood up, he probably would have slipped and fell.
That's fantastic. Were either of you skeptical when you first heard about this program, and how did you overcome that? Kirsten.
I wouldn't say that I was skeptical. I would say that I was kind of intrigued as to how it would work with floor staff, how much we would really be able to help them and prevent patients from falling. I actually was just so interested in it that I don't think I had any hesitancies with it. And so, that first week, it was my goal to make sure that I did my best. Every day it was always my goal to do my best when I was monitoring. But as a supervisor now, I see from different areas and different perspectives on how we can improve and how we can do better. And every day my team is trying to do their best.
Great. Did you have any skepticism at all, Juliet?
No, for it was interesting, as in coming from a long-term care and coming in here and hearing about this program, as in they had already started before I came on board. So being trained by the monitor staff to actually see what they actually do and going on the unit, speaking with the nurses, as in I was really interested to know, okay, how could we grow this program from what it was when it was started, but now that I've taken over. So I'll say I was ready for the challenge, because I know one of the challenges they had was getting staff nurses to get on board. So to
Sure.
me, I saw that as a challenge to see, okay, what are they going to do different to get this program heading the right way?
Yeah, and we're going to talk about that in a little bit, Juliet, because I know you've got some experience with that. One of the things I want to know while we're on the topic of, your first times monitoring and interacting with patients, one of the most important things that a monitor tech has to do is develop a relationship with the patient. And it really can make or break the program. And so how do you develop relationships with your patients? And are you finding that if you do some things to develop a relationship with your patients, that it's more effective towards the redirecting of the patients? Talk a little bit about that, Juliet.
So
or how you train your staff to do that.
Yeah, like I said, I have a great team. And the way they relate with this patient, sometimes I'll be at my desk and some conversations I hear them talking with the patients, I'm like, okay, really, you guys. So most of them, they'll talk and say, hey, Mr. Jones, do you need some help? Just hold on, let me call your nurse. Or how you doing today? Just conversing with the patient sometimes. And, just simple things like, oh, let me get your nurse. Then they go back and tell Mr. Johnson, oh, your nurse is coming, give her a few minutes. And they say, thank you. So that goes a long way to say, okay, somebody actually listened and is giving me a feedback. So I think that kind of goes a long way with them. And when they go hook up a camera, I always tell them, introduce yourself, tell them what the camera is for. The next person, the monitor tech, going to watch them, introduce themselves, talks to them. And some of them, the patient, they'll say, oh, no, I'm not going to get up this alarm. Even we had the fall prevention week sometime last month, and a patient actually recognized one of the staff by her voice. And he said, oh, you that monitor staff that keeps telling me do not get up. So we all laughed about it. And, she just kind of explained, I'm just trying to make sure you're safe. And that's why I tell you don't get up. I'll call your nurse. And you see, you just coming for an outpatient appointment. So it was kind of good that's how they have that rapport with the patients. And I think the more they kind of talk to them rather than just using the verbal announcements, it makes the patients know, okay, there is somebody on the other side I am speaking to, not just Big Brother watching me.
I love that story. We have in our company, as we talk with monitor staff, have heard a lot of fun things that the patients say to the monitor techs. And so I'm sure you've had some chuckles throughout your time. Kirsten, tell me a little bit about how you develop relationships with the patients.
So Juliet's 100% right. You have to be able to talk to those patients, converse with them. My team will do that. We'll get to know the patient. We'll talk to them probably on that first verbal cueing, where we have to say, do you need something? How can I help you? We introduce ourselves. But I do patient rounding as well on patients who are on the systems, but also not on the systems. And when I do that patient rounding in person with patients who do have a system in the room, I introduce myself. I tell them about the camera, a little bit about the program. If they are able to understand and converse, they do ask questions, and family will ask questions as well. So I do kind of go over those things with family and patients in person. And then sometimes I do have the staff talk to the patient when I'm in the room. So it'll look something like I'll wave at the camera, and then my team will see me and they'll say, hello, Kirsten. And then I'll say, would you please go ahead and introduce yourself to this patient? And then they will, and then the patient will giggle and they'll wave. And then the monitoring team can say, well, if you need anything, you can wave at me. And most of the time I'll be able to get back with you. And that does encourage the patients to also try that as well as the call lights to get help.
You know, as you were talking, Kirsten, something occurred to me. You're in a hub and spoke model, correct? So
Yes,
you have
ma'am.
a hub where you monitor patients not only at your facility, but at other outlying facilities in the area. So is that a challenge with developing a relationship with patients? How does your monitor staff overcome that? And what do you think could, if they're not overcoming that, what could an improvement be on that?
Well, I think that speaking to those patients, just as Juliet had stated, introducing yourself really does go a long ways. Having those conversations with them or their family while their family's in the room, even if they are 2 towns away or 2 hours away, we can still have that relationship with them and converse with them. So I really think that my team does a really great job of instilling that with those patients.
So you don't necessarily need somebody like you rounding on the patients to facilitate that introduction. Your team has learned to do that even from a remote location, and how
Yes,
important
ma'am.
that is.
Yes.
What do you do if there's a monitor tech that doesn't do those introductions well? Is that part of your training plan then, to make sure that that's a part of their standard work? Kirsten?
Pardon me. Yes,
Yeah.
it is. That is something that we do train on at the beginning of their
Great.
training. And so they do learn those kinds of things as well as troubleshooting and how to build a rapport with the staff as well as the patients that are at other campuses. We do touch base on that. And if they don't do it right away, then it's just a learning curve. We just encourage them further and remind them to talk to those patients and build that trust.
So now you've developed this relationship with the patient. The monitor staff are monitoring multiple patients, 10, 12, 14, 16 patients at once, and the new shift comes in. So it's really important, I know from experience with bedside nursing, that it's really important to give a succinct and useful report as to what happened during the day and what needs to happen and what things are happening with the patient. How do you both train your staff to do that in an effective way? So number one, patients are still safe and there's still monitoring occurring. And number two, they're getting a good report from one shift to the next. Juliet, I'll start with you on that one.
Okay, so when I started the program, that was one of the things I found that they weren't given a proper hands-off report, as in something was getting slided along the way. So I developed like a hands-off report sheet where during the process of monitoring, because we do 8 hours, if there's anything going on with a specific patient or something, they can just write it down. That way, at the end of the shift, everything that happened on that shift, they're able to pass on to the next shift. Now, the hands-off report stays with the next person. So they can make a copy, to kind of go back and say, okay, what did this person tell me about this patient on camera 8? Or, okay, he likes to sit on the side of the bed. Or he's someone that would try to go out of the room if nobody's sitting outside. So that hands-off report kind of helped, and that way it continues the care. So if there's something they need to confront from a nurse, everything is written down in the hands-off report sheet they have. So they still have it during the shift for continuous of care. So even when I come in like 2 days later, I can still go back and look at, okay, what was going on with these particular patients during this particular day. And I think it kind of helps because the nurses also, one nurse comes in and says one different thing. Another nurse might say, no, I want you to watch the patient, hit the start alarm if he does this. So when the staff come on shift too, they'll call, okay, they'll speak to the other nurse, saying, okay, the previous nurse said, this is what they wanted us to do while watching this patient. What do you want me to do while I'm watching this patient? Because on report, this is what I was told. So that communication goes from the monitor tech also to the nurse, because the initial admission, hands-off we get from the nurses is on admission. So when we're admitting a patient, they tell us, we say, okay, give us a brief history. What's going on with the patient? What do we need to look out for? What is the main reason you want this patient on camera? Because if you're telling me I'm watching a patient for elopement, that's going to be different if I'm watching a patient that had a previous fall. Because most elopement patients, their gait are kind of steady and they will leave right away. But with a fall, it will take a while before they get out of bed. So they have to actually tell the monitor techs what is the primary reason this patient is being monitored. So that way they can pass it on to the next shift saying, okay, this patient, he's more of an elopement patient. You have to watch him. If he steps at the door, he does left and right and nobody's there, he would leave. This other patient, if they're dirty, this is what they try to do. Just know you need to call the nurse, and that's why they're trying to get out of bed. So those are the kind of reports I always expect them. I said, give specific report about specific patients. Don't just generalize each patient, because each patient is different. So you have to give a specific report for each patient.
So with that being said, Juliet, you talked a lot about the nurses giving a report to the monitor staff and then the monitor staff handing that patient off to the next shift, the next monitor staff shift.
Yes.
Do you have a process set up for the monitor staff to get updates from the clinical staff for any changes? What if they end up having an IV restarted during a shift and they need to watch for that, and now they're looking for line and tube dislodgement in addition to monitoring for falls? How does that information get back to the monitor staff?
So usually the nurses will call
and
say, oh, who's watching this patient? I just want to let you know we recite his IV, or just give them any updates they need to. And sometimes even the monitor techs, they know if they see an IV team come in and they're putting an IV, they will call and say, oh, are you taking out the IV or are you putting they see all the stuff. So they most times will call the nurse to get updates. Like yesterday we had a patient that was out. He went for surgery. They knew when they admitted him, he still had his left foot. So I guess in the process of them transferring the patient, the tech noticed, oh, he has a bandage around his left foot. So she called the nurse and said, oh, I see this patient just came back. Did he just have surgery? And the nurse said, yes, he just had a left foot amputation. So she went ahead and updated her additional notes. So the techs still see what's going on. They don't always wait, except it's something, if a patient is on go lightly and they know, okay, he's going to be going to the bathroom more often, then they'll call and let the techs know, so that way they're not just starting. So the communication is pretty much two ways. There's no an exact process, but like I tell my team, just be focused, be vigilant on things, because sometimes nurses get busy and they're like, oh, I'm going to call the team, and they forget. But the techs, when they see it, they're able to call the nurses and verify information.
It sounds like that your techs are very observant and very inquisitive, and that's fantastic.
Yes, they are.
Kirsten, I want to hear about how this works at your hospital and in your program, especially with it being a hub and spoke model. Talk to me a little bit about the same question, how the monitor staff give report to each other, and then how they get updates from the bedside.
So they will have the person who is leaving be sitting at the station, and they will be giving a verbal report based off of the notes that are on the screen to the left of the AvaSure program. And those are updated each shift. And then they will let the staff member who is taking over know this patient has been very busy. We also have a book or a binder for each station that has paperwork on each patient. And we do keep track of when we've called on patients. And then we relay it to the new oncoming staff member that those patients have been very busy, or they've pulled lines, or they tried to elope, what have you. And then between 9 and 11 at each shift, we do call the nurses because we know that they are getting a report. We know that they are then passing meds, and sometimes they're unreachable. So between 9 and 11, we do call and get an updated report with that nurse as to how they would like to be taken care, or the patient taken care of, up until we can get an updated report as to any changes on primary condition or secondary reason for monitoring, or primary reason for monitoring. We do monitor as if we were monitoring for the prior nurse with their instructions. It does not vary from hospital to hospital for us. We do it exactly the same. The only exception would be that our hospitals that are long distance, that we have to call long distance on, we generally will hit the prompts, or we'll talk to the patient, then we hit the stat alarm, then we call them. Versus here at our main hospitals, we do prompt them, and then we call, and then we hit the stat as we're calling. We do put that extra little safety precaution of those stat alarms in there for the ones that are long distance.
Is that because you have to dial the long distance number?
Yes,
Okay.
ma'am.
And so I don't
Yeah.
think that every hub and spoke uses that method. I think that there are sometimes some ways to communicate within a system without having to do that, but it sounds like yours does, and you've figured out a workflow to make it safer for the patient. So that's great. So this is not a job that you can do alone. There is so much teamwork involved in not only in being a monitor tech, but in working with and becoming part of the bedside care team. And it sometimes can be a challenge, and we need to address those challenges. And I want to understand how you think your job could be done more effectively or better in relationship to the teamwork between you and the bedside nurse. So talk to me about the level of teamwork you have, either the positives of that teamwork, or if you feel like there are any negatives, the negatives of that teamwork, and what you want nurses to know about your role and your job. We'll start with Kirsten.
I really think that we always aim to do well as far as teamwork goes. Communication is absolutely the most important. And it also can be the thing that we lack on a little bit. We lack communication at times. That's always somewhere that we can improve. So whether it's communication from us to floor staff, or floor staff to us about changes on a patient, that's probably the biggest area that we could improve.
Juliet, how about you? I know that you do a lot of work and a lot of walking around the units and assessing patients for appropriateness. Does that involve talking with the bedside staff and alleviating concerns and helping them look at the monitor staff as more of a team member? And how do you do that?
So like Kristen said, communication, that is to be the major thing I think I have found out. And not just clear communication. We have to listen, they have to listen to us. If I do rounds on the unit, I probably ask the nurses, oh, okay, how my monitor techs doing? Do you have any concerns? Because if they have a concern about the patient they're monitoring, that is going to prevent me from talking to them or putting another patient on camera. So when I ask them, okay, tell me your concerns, what can I do to make sure you have a good day and we're not just hitting the start alarm. And if they tell me, I take it back to the team, we have a little huddle in the month and say, okay, this is what the nursing staff is complaining about. How do we get better? The same thing if my staff is saying, oh, they try to call the nurses, nobody's picking up. I go to the unit, I said, hey, my staff is trying to reach you guys, as in, we use Vocera. You have to be logged into Vocera. We need to reach somebody if that start alarm goes out. Somebody needs to be reachable. For example, I was doing rounds one day and a tech said, oh, why is it that every time we call for privacy, you give us privacy, then you turn it back up right away. Then I explained to her, I said, when you ask for privacy, the monitor techs are telling you when you don't, you need to call us, because we've had a situation where staff will walk out of the room and forget to call. So if you see them turning it back on, it's because they probably ask, are you done? Or, you already left. It takes a second for a patient to fall once we don't have visual. So they will turn that privacy back on. And she's like, oh, okay. I said, yes. I said, that is why we need to communicate. You need to call us and let us know when it's done. The staff try to give that privacy for that patient. So the fact that we're visually monitoring them doesn't mean the patient don't need their own privacy. So you need to communicate with us. Same goes for the nurses. I let them know you want a patient on camera. You put a tele to the order. My techs don't know the order is in. If you don't call us at the time you put the order in, you will not be getting that camera right away. So maybe you put the camera like an hour ago and it's almost shift change. You don't expect the staff to come hook up that camera because they have to do the report. So you need to communicate. You put the order in, you call us right away. We need the patient to be on camera. And the same thing when I do rounds, when I see a patient on a one-to-one, I go and I speak to the sitter. I say, oh, what's going on with this patient? Because most times the sitter have a better idea than the nurses. I said, okay, so what has it been today? What was your report from the ongoing shift? Then I go speak to the nurse. I said, oh, this is what the sitter told me. If the nurse is kind of skeptical, I understand. I'm a nurse too. I say, you know what? I will come again tomorrow. Let me give you some time to assess the patient, because sometimes you go when the nurse will say, you know what, this is my first day of having this patient. Let me assess them, which is understandable. I listened to them. I said, okay, you know what, go ahead and do your assessment. Tomorrow I'll be back to see if we can actually get this patient on camera. And like I said, sometimes, a patient comes in, they're confused. You already know they're not going to be a good candidate because they'll be non-redirectable. They'll have to be hitting the start alarm all the time. And that's taking time from the other patient that the staff is watching. So I kind of listen to them also. And the same thing, I was telling my monitor techs, I said, if a nurse tells you no today, that doesn't mean they'll tell you no tomorrow. So just listen to them and say, okay, I understand. We understand the patient just came in. We'll check back tomorrow. So every shift, I try to tell the monitor tech, speak to the nurse, because the fact that this nurse refuses, the next nurse might say, oh, okay, yes, he's good. Let's try him on camera. And I always explain to them, I said, during the 2-hour trial, you will have your sitter in the room. We are not just pulling your staff out. If the patient passes, you get an additional staff back on the floor. If it doesn't, we're going to keep, because it's all about patient safety. So
That's great.
Yes.
That's great, Juliet. As you're talking and all of the interaction that you do with the staff, it kind of makes me want to ask this next question. And over the years, we've heard that sometimes there's a disconnect between the staff at the bedside and what's going on in the monitoring room, and a lack of communication or lack of knowledge as to how the system operates and what the monitor staff are doing. And vice versa. The monitor staff may lack understanding of why isn't the nurse answering the phone? Why can't I get somebody into the room? Kirsten, talk about, do you have both ways in your hospitals an escalation process where you can address the concerns of the bedside staff and the bedside staff can address any concerns that might be in the monitor station?
Yeah, so if a monitor tech is having a problem getting a hold of floor staff, they will try the PCT first, then the nurse, then the charge nurse. And if they're having troubles getting a hold of any of those staff members, they will reach out to me. We'll verify that staff member's phone number, ensure that they have their phones with them. I'll call the desk number, or I'll go out to the unit and kind of check with them and make sure things are going well. If floor staff has an issue with us not communicating or talking to the patient, they will also reach out to me. I have gone unit to unit in the past, and while I was doing patient rounding, kind of reached out to those nurses and asked, just like Juliet, how are things going? Can I help in any way? Can I make things better? And their feedback is sometimes they don't hear the monitor staff talk to the patient first. And I always educate them that if you don't hear us speak to those patients, go ahead and give us a call. Allow us to turn the volume up on our devices, because now we have that ability. And then that really does help. Or I call while I'm standing right there, and I encourage my staff to turn that volume up for the nurse, and then we test it out and I say, is that better? And if they think that it's better, then we just move on. It's an easy fix. As far as phone numbers, I will verify with the nurse that their phone number is correct, that my staff has that phone number. And I encourage the staff to call me or email me or reach out to me. And if they think that their patient has not been being monitored appropriately, I can also double check the AvaSure dashboard, which I absolutely love because I can take it down on my laptop and show them. We've talked to this patient 5 times in the last 2 hours. We've talked to this patient 10 times in the last 24 hours, or what have you. And it really helps them to see and understand those prompts and the trend that that patient has had.
Great. So we have about a little more than 10 minutes left. And I have a couple of more questions, but I'm also getting some really great questions from our audience. So I'm going to sort of mix in towards the end, and then we're going to end the session, of course, with great catches. So more to come on the great catches, but I think that this is a fantastic question. And, you know, monitor techs sometimes witness upsetting events. You are there to provide constant observation to patients in rooms. So how do the leaders in your hospital, or how do you support your monitor staff when that happens? Kirsten.
So I have had staff who have not had hospital experience before become monitor techs. And let's say a patient passes away during their shift, and we've had this happen just in the last 6 months. They called me middle of the night. They were upset that their patient had passed away. They weren't really sure how to handle the situation or if they had handled it appropriately. The patient had passed away of natural causes. I answered my phone. I am very open to them, and I tell them, if something happens you're not comfortable with, call me. I will answer. You may have to call me a couple of times, but I'll be there. So they called and I answered, and I just listened to them. And then I followed up with them the next morning and made sure that they were aware that they had done everything right. They could not have done anything better. And that it's okay to be upset that we have had a loss. And I walked them through that. And then I offered them our services as far as a minister goes. Nice. I did ask them, would you like to speak to somebody else who might be able to walk you through this at a better way? And I gave them the phone number that we also have from our hospital for staff to call when they have mental issues as well.
Great.
And so that was very helpful. And we touched base with it several times after the occurrence. I didn't want them to think that I had forgotten them or that their patient was forgotten either, because we monitor these patients sometimes for a very long time.
Yeah.
And we do get to know them, and we are like a second family to them sometimes. And it is hard.
Juliet, I'm going to ask you the same question, but talk a little bit about if a monitor staff member witnesses an adverse event, and maybe a fall occasionally occurs, and how do you help your staff process that?
So we've had a staff member who a patient fell, and we went back. She kept saying this shouldn't have happened and all that. So I did go back, went to honor to see, okay, we did everything, all the interventions we could have done. We hit the start alarm, we redirected the patient. Thank goodness there was no injury, but they felt there should have been more they could have done to prevent that fall. And I said, we did everything we were supposed to do. We hit the start alarm, we overhead page because that's what we also use to get staff member. But if a patient is going to fall, they're going to fall. We can only intervene as quick as possible to prevent it. So I say, don't beat yourself about it. It will happen. We're just going to learn and see, okay, what would I have done different to make sure to prevent that fall from happening in the future. And even sometimes the nurse will actually call and say, you know what, you guys did what you were supposed to do, because that patient, he was so fast and he felt the nurse was still at the door
Yeah.
when it happened.
Yeah.
So, but the tech felt, okay, it's something she should have done. I said, no, we did everything. Even for the nurse to call and said, thank you, you did everything you were supposed to do to prevent that fall. And like Kristen said, we all, especially the techs, they get attached to these patients
Mhm.
because some of them stay on camera for like a whole month and go home, or some don't even go home. And I have a patient that actually passed, and the day the patient passed, the night tech said, "Oh, he likes pudding. I'm going up to his room to get him pudding." And I think along that way, she didn't end up going. And the next day when she came, she found out he had passed away, and she was kind of upset. She said, "I should have just, as in, I wanted to go. I should have just gone." And I said, "You
Oh.
know what?" I said, "It would have made no difference. I understand you wanted to at least go before it happened, but it already happened. I know he will be glad that while he was on camera, you kept talking to him. When you're on lunch break, you would take him pudding. So you make sure in your own way he was comfortable
Oh.
before he passed."
That's
So
a really great story. Thank you for sharing that. And it sounds like you're using the dashboard and the event logs to reassure your staff that they're
yes.
doing everything that they can and that you can show them that. That's fantastic. Juliet, you have the special honor of working in a VA hospital where you're caring for our country's veterans.
Yes.
Is there anything special you have to do different that you have to do with your monitoring program in order to consider what some of those veterans might have gone through and how to monitor them, maybe specifically to the alarms or to talking with the veterans through the devices? Is there anything special and advice that you can give to other VA hospitals?
So pretty much before, I always tell the monitor tech, once you take that camera into the room, you introduce yourself and explain to them what the camera is for. Bear in mind, our population, most of them suffer from PTSD. You don't want to be sounding that alarm just like that. So we test the alarm, we test the verbal command. We tell them, if you're trying to get up or you're putting your lines, this is what you would hear. And the monitor takes plays back the information saying, okay, attention, do not get up. Gives them an idea what they're listening to. Because I don't want to wake up and I'm hearing somebody say, attention, do not get up. I'm gonna be scared. I'm probably gonna fall. So I tell them, you need to go ahead, explain to them what it is, hit the alarm and say, if you try to get up, this alarm will go off. Now, this alarm is to notify staff that you need help and to come into the room. And I make the monitor techs, they play the alarm so they can have a feel of what it sounds like. So I think all that kind of helps them because, like I said, our population, especially with PTSD, I'm not a vet, but I know I work with a lot of vets and I know a lot of them to talk about that. So you don't want an alarm going off just like that. It will take you way back to whatever days or years you were in the Army. So we always try to play. Now, if a patient is sleeping, I tell them, do not sound it.
Okay.
When they're awake, we kind of talk to them and say, hey, this is what we're doing. This is how the alarm sounds like. So
Right.
just to give them a heads up of what they would hear if something goes wrong.
Those that's really good advice. Hopefully some of our other VA hospitals who are using this system were able to hear that. I think that's very sound advice. All right, we're at the fun part. Let's hear some good catches. Good catches are one of our mottos. We love to ask our customers about good catches. I think at the end of every segment so far, we've heard a lot. Pick your favorite one, Kirsten, and share with us what you or one of your staff members were able to do for to keep a patient safe.
Sure. So I actually had a patient in 2-point restraints, and floor staff just kept saying, there's no way they're going to get up. There's no way they're going to get up. They're restrained. And I kept saying, well, I understand. However, their legs are going over the edge of the bed. And somehow this patient got their lower half of the body out of the bed, over the bed rail. And I hit the stat alarm. My coworkers at the time, one called the nurse, one called the charge nurse. I was calling the PCT. We were all three on the phone at the same time. And luckily, staff got into the room before the patient officially got onto the floor. They had long enough arms that they were able to climb over those rails and essentially like stand while kind of bending over. So we were able to prevent that patient from falling.
Great. That's great. Juliet, how about you?
Okay, so like I said, the Telemetry is so good that it's not just for fall prevention. So when we admit patients, we do that to our trial. When, the techs, they communicate with the patient before they go and they start the admission process. So on this particular day, a patient we were already starting the admission process. They went to the room, spoke to the patient, they checked all the sound and everything. And the monitor tech was about admitting the patient, and she said, something doesn't look right. This is a patient she just spoke with on the camera a few minutes ago while we're testing audio and the start alarm. And she told me, she said, this patient doesn't look right. So I said, call the nurse. And really, when they stepped into this room, this patient was unconscious. They had to call a rapid response right away.
Wow.
So you can imagine if that patient at that time was not being on camera, anything would have happened. But thank goodness, as in he was able to transfer to the ICU right away. So with the staff being, like I said, my staff, they are very inquisitive. They will look, they pay attention, and if they see something is not right with the patient, so they're not just looking at falls. Like I told them, I said, you guys are watching these patients 24 hours. Anything you see that doesn't seem right, you need to call the nurse. Do not follow your instincts. Something is not right. So the nurse actually called the monitor room to thank the tech, say, thank you for alerting us on time.
Great story.
Yes.
Fantastic. Wow. It's always so much fun to end with that. I think Dave is going to come back up here to close out today's session. But I want to thank you both so much for participating in this. The monitor staff for telesitting programs are so important. This couldn't happen without you and without your teams. You help people keep people safe, just like we help people keep people safe. So we're all in this together. Thank you so much for everything that you do, and thank you for participating today.
Thank you.
Thank you.
Boy, that was amazing information. Thank you so much for sharing your stories. Juliet, Kirsten, Stacy, nice job with the conversation. Offline and off camera, a number of us, shared our stories and points about this afternoon, how probably 2 or 3 times got a little choked up in terms of what we were hearing and appreciation of what everyone's doing. We can't thank the speakers enough for sharing your time and examples throughout the day. I wanted to just highlight a few themes along the way. Number one, we heard about the importance of building trust with nurses and with the teams that care for patients. We heard about hubiversaries and the important role of hub and spoke or centralized monitoring, and even talked a lot about how technology plays a role in the future of caregiving. And so those 3 themes carry till tomorrow. So I really want to point out for day 2, please join us. The first session is creating awareness, confidence, and excitement. It's about being change agents, about managing that change. Number 2, optimizing labor across an entire health system. That's that hubiversity, that's that centralized monitoring, that's that one of the models of care that really drives great patient care as well as some ROI. I'm thinking Gay Landstrom from a webinar we just did, more on that with a panel discussion tomorrow. And then we're going to close out with a leadership fireside chat with our CEO, Adam McMullen. He'll be joined by Jerry Lewis again. Jerry served as the Senior Vice President and CIO at Ascension Health. They'll really talk about where this is all going, how technology plays a role in our future. So I wanted to mention that we're going to keep the platform open for more interaction. Please stay on and connect. I think that's until 4:30 Eastern time that the platform will be available. We saw a number of questions, and we're going to follow up on those. We're going to share more information tomorrow. So reminder that tomorrow our virtual doors open at 12:30 p.m. We'll kick things off at 1 p.m. and be well, and we'll see you tomorrow. Thank you, everyone.